surgical team requested nasotracheal intubation due to intraoral manipulation. They prefer the north face, right angle endotracheal tube. Fiberoptic intubation with this kind of convoluted north face tube is much trickier than with ordinary tubes. Taking advantage of the multi-hole tip of the epidural catheter, we used it to spray a mix of lidocaine and oxymetazoline inside the nostrils with minimal discomfort to the patient. After applying 2% lidocaine in each nostril, we applied 10% lidocaine. We asked the patient to hold his breath while applying 2 puffs in each nostril. We add some 2% lidocaine gel in order to provide lubrication. Some extra drops of oxymetazoline to provide a good vasoconstriction and avoid bleeding. At this point, the infusion pump administered the patient in 3 minutes a bolus of 1 microgram per kilo of remifentanil, and the infusion continues 0.07 micrograms per kilo per minute. We choose scope first technique for the sake of the movie. After getting lost with some pink outs, we eventually found the tip of epiglottis and the vocal cords. We tried to maneuver the tip of endoscope in order to put the epiglottis in the center of the screen. The epidural catheter is threaded through the working channel of the fibroscope in order to administer 2% lidocaine at the base of the epiglottis and over the vocal cords. The patient was previously warned at this point that a urge to cough might appear. In spite of that, only mild erection occurred due to lidocaine dropping over the cords. Since the view was not the best one, we decided to withdraw the scope and clean the lens, wiping it out of the secretions. Once again, we introduce the endoscope through the nair and get lost with some pink outs inside the nose. After finding the tip of epiglottis and the vocal cords, the epidural catheter is now threaded through the vocal cords to anesthetize the subglottis, that is territory of the recurrent laryngeal nerve. Superior laryngeal nerve territory is properly anesthetized, and we can see that by the lack of reaction of the vocal cords in contact with the catheter. We can see the movement of vocal cords according to the respiratory phase, and we can realize the expiratory gas flow of the spontaneous ventilation, but there is almost no reaction of the patient. Now we are going to administer lidocaine with the catheter below the vocal cords in order to increase the acceptance of the tube. In spite of the inadvertent touch of the carina with the epidural catheter, there were no cough reaction of the patient. With the carina in sight, the tube is introduced into the trachea using the scope as a rail. Since the patient remained comfortable, conscious, and breathing by himself, we were not in a hurry to induce venereal. I'd like to point out the normal values that the monitors are showing at that time. Smooth induction of anesthesia is done by the breathing of a mix of nitrous oxide and sevoflurane by spontaneously breathing patients. Typical capnographic wave confirms the proper position of the endotracheal tube.